Welcome, and thank you for joining this in-depth clinical review. Today, we turn our attention to one of the most common and challenging areas in pediatric medicine, the diagnosis and management of asthma in children under 5 years of age. This is a topic characterized by diagnostic uncertainty, evolving therapeutic strategies, and a high degree of caregiver anxiety. The clinical picture in this age group is often complicated by the frequent overlap between viral-induced wheezing and the inception of true, persistent asthma. For years, this ambiguity led to varied and often inconsistent management approaches. However, the landscape has been significantly clarified by the Global Initiative for Asthma, or GINA. In this episode, we will undertake a comprehensive exploration of the GINA 2025 Global Strategy for Asthma Management and Prevention, focusing specifically on its guidance for children aged 5 and under. We will delve into the fundamental pathogenesis of early life asthma, detailing the interplay between genetics and environment. We will then walk through the pragmatic, criterion-based diagnostic framework that GINA has established, a major shift away from older, less reliable phenotype classifications. Following that, we will meticulously examine the evidence-based, stepwise approach to long-term management, including the nuances of pharmacological therapy and device selection. We will also cover the critical management of acute exacerbations, integrating the latest updates and evidence. Finally, we will discuss ongoing monitoring, special considerations, and the importance of a partnership with caregivers to achieve the ultimate goals of therapy, to control symptoms, minimize future risk, and allow the child to live a full and active life. Pathogenesis and primary prevention. The origins of asthma in early childhood are a complex tapestry woven from threads of genetic predisposition, immune system development, and a vast array of early life environmental exposures. This period, from gestation through the first few years of life, represents a critical window of opportunity where the trajectory of respiratory health is established. The GINA 2025 strategy provides a sophisticated framework for understanding these intricate beginnings, moving beyond simplistic explanations to embrace the heterogeneity of what we observe clinically. For decades, clinicians have struggled with the common presentation of the wheezing preschooler. We developed descriptive labels like episodic viral wheeze, for children who wheezed only with colds, and multiple trigger wheeze, for those who also had symptoms between infections. While these classifications were an attempt to bring order to a confusing clinical picture, their utility has proven to be limited. They have core predictive value for identifying which children will go on to develop persistent asthma later in life, and they often led to inconsistent treatment. GINA 2025 decisively moves away from this phenotypic labeling. It advocates for a unified, criterion-based diagnostic approach, acknowledging that while the underlying biological pathways may differ between children, a diagnosis of asthma can be made based on a characteristic pattern of symptoms and, crucially, a documented response to asthma-specific therapy. This represents a fundamental shift in clinical practice, moving from a passive, watchful waiting approach to a more proactive, test and treat model, which has the potential to significantly reduce the morbidity associated with uncontrolled symptoms in this vulnerable population. At the core of early childhood asthma is a process of aberrant immune programming. The development of asthma is not a single event, but a cascade of interactions that shape the maturing immune system. In this early period, a crucial balance is set between T helper type 1, or Th1, and T helper type 2, or Th2, immune responses. A healthy immune system maintains equilibrium between these pathways. The Th1 pathway is primarily involved in responding to intracellular pathogens, like viruses. The Th2 pathway, on the other hand, is geared towards extracellular parasites but is also the central driver of allergic inflammation. In children who develop atopic asthma, this balance is skewed towards a Th2 dominant response. This results in the overproduction of a specific set of signaling molecules, or cytokines, namely interleukin-4, interleukin-5, and interleukin-13. Each of these plays a specific role in the inflammatory cascade. Interleukin-4 drives the production of immunoglobulin E, or IgE, the antibody responsible for allergic reactions. Interleukin-5 is critical for the development, survival, and activation of eosinophiles, a key inflammatory cell in the asthmatic airway. And interleukin-13 promotes mucus production and airway hyperresponsiveness, the tendency of the airways to constrict in response to various triggers. This Th2 skewing is the fundamental pathophysiological hallmark of atopic asthma. This understanding has profound implications for public health, as it suggests that primary prevention strategies must be targeted at pregnancy and infancy to be effective. GINA 2025 presents a nuanced perspective on environmental exposures, which aligns with the broader concept of the hygiene hypothesis. This hypothesis posits that a lack of exposure to a diverse range of microbes in early life prevents the immune system from being properly calibrated, leading to an increased risk of allergic and autoimmune diseases. Certain exposures are clearly detrimental. Exposure to environmental tobacco smoke, both in utero and after birth, is one of the most significant and entirely modifiable risk factors for the development of asthma. Similarly, exposure to outdoor air pollutants like nitrogen dioxide and particulate matter is consistently associated with an increased risk. However, a lack of other exposures can also be problematic. For example, children born via caesarean section, who are not exposed to the maternal vaginal microbiota, have a higher risk of developing asthma. The widespread use of broad-spectrum antibiotics in the first year of life, which can drastically alter the composition of the gut microbiome, is also linked to an increased asthma risk. Conversely, protective effects have been observed in children raised in traditional farm environments. This farm effect is attributed to exposure to a rich diversity of microbes from soil and animals, which helps to promote a balanced Th1-Th2 response and the development of immune tolerance. This creates an interesting paradox. Cleanliness from pollution is beneficial, but cleanliness from a wide array of microbes may be harmful. This suggests that primary prevention is not just about avoiding harmful triggers, but also about actively curating a healthy set of early life exposures to promote robust immune health. When counseling families, it's important to synthesize this evidence into practical advice. Regarding diet, current evidence does not support specific maternal dietary restrictions, such as avoiding peanuts or milk, during pregnancy for the primary prevention of asthma. In fact, some observational data suggest that maternal intake of certain foods may even be protective. For infants, breastfeeding is strongly encouraged for its multitude of health benefits, but its specific role in preventing asthma remains unproven. The use of specialized hydrolyzed infant formulas is not recommended as a primary prevention strategy. The most impactful advice for families remains the complete avoidance of tobacco smoke exposure. Furthermore, addressing factors related to maternal health can also be important. Maternal obesity, high weight gain during pregnancy, preterm birth, and low birth weight have all been identified as risk factors for the subsequent development of childhood asthma, highlighting the importance of comprehensive prenatal and perinatal care. Clinical diagnosis and investigation. Diagnosing asthma in children under 5 has historically been one of the great challenges in pediatrics, a landscape often clouded by uncertainty. This has led to the use of provisional labels and, in many cases, significant delays in initiating appropriate management. The GINA 2025 report represents a landmark shift, confirming that a definitive diagnosis of asthma not only can, but should, be made in this age group. It provides a pragmatic, criterion-based clinical framework that brings much-needed clarity and consistency. This framework is not designed to predict the long-term future of a child's respiratory health, but to accurately classify their current clinical condition, enabling timely and effective treatment. The approach is built on 3 essential pillars. First, recognizing a characteristic pattern of respiratory symptoms. Second, carefully excluding alternative explanations for those symptoms. And third, documenting a clear and timely clinical response to asthma-specific therapy. Let's break down each of these criteria in detail. The first criterion is the pattern of recurrent respiratory symptoms. The diagnosis hinges on identifying a history that fits one of 2 specific patterns. The first pattern is a history of at least 2 acute wheezing episodes within the past 12 months. An acute wheezing episode is defined as a distinct period of asthma-like signs, such as audible expiratory wheezing, observable use of accessory muscles for breathing, or shortness of breath, that lasts for more than 24 hours. The second pattern that satisfies this criterion is a history of at least 1 such acute wheezing episode, coupled with the presence of what are termed interval symptoms. These are asthma-like symptoms that occur between the acute episodes. Classic interval symptoms include a troublesome dry cough or wheezing that occurs during sleep, with physical activity like running and playing, or with emotional expression such as laughing or crying. A critical component of this first criterion is the objective confirmation of wheezing. Parents and caregivers often use the word wheeze to describe any type of noisy breathing, which could be anything from the gurgling of upper airway secretions to the snoring sound of laryngomalacia. Therefore, it is essential that on at least 1 occasion, the presence of true expiratory wheezing, consistent with lower airway obstruction, is confirmed by a trained healthcare provider. This can be done through direct auscultation during an examination, or increasingly, by reviewing a video or audio recording provided by the parent. The second criterion is the exclusion of alternative diagnoses. Before a diagnosis of asthma is confirmed, the clinician must conduct a thorough medical history and physical examination to ensure that no other condition is the likely cause of the respiratory symptoms. It is important to remember that the presence of a concurrent viral respiratory infection does not exclude asthma. In fact, viruses are the most common trigger for asthma exacerbations in this age group. The key is to look for red flags that point away from asthma and towards an alternative diagnosis. These red flags include symptoms that have been present since birth, failure to thrive or poor weight gain, vomiting that is associated with respiratory symptoms, the presence of continuous wheezing that doesn't vary, or a complete failure to respond to appropriate asthma medications. The list of differential diagnoses is extensive. For a child with a persistent wet or productive cough, one must consider protracted bacterial bronchitis or, in some settings, tuberculosis. If the onset of symptoms was sudden and associated with choking, an inhaled foreign body is a primary concern. Noisy breathing that is present when the child is crying or eating, often with a harsh, barking cough, might suggest tracheomalacia. Other considerations include congenital heart disease, particularly if there are cardiac murmurs or failure to thrive, bronchopulmonary dysplasia in a child with a history of prematurity, and cystic fibrosis, especially if there are accompanying gastrointestinal symptoms. A history of recurrent infections beyond the respiratory tract might point towards a primary immunodeficiency. The third and final criterion is the documentation of a timely clinical response to asthma therapy. This serves as a vital therapeutic confirmation of the diagnosis. A clear and positive response to asthma medication provides strong evidence that the underlying pathophysiology is indeed consistent with asthma. This response can be documented in one of three ways. First, during an acute episode in a clinical setting. In a child presenting with an exacerbation, a documented improvement in respiratory signs and symptoms within 20 to 60 minutes after the administration of an inhaled short-acting beta-2 agonist, or SABA, supports the diagnosis. For more severe episodes, improvement within 3 to 4 hours after a combination of SABA and oral corticosteroids is also considered a positive response. Second, a response can be documented based on caregiver reports from home. A convincing and consistent report from a parent that the child's wheezing or difficulty breathing reliably improves within 20 to 60 minutes of receiving SABA at home is also valid. Third, for children with more frequent symptoms or a history of severe exacerbations, the response can be documented through a formal controller trial. This involves a 2 to 3 month trial of a daily low-dose inhaled corticosteroid, or ICS, plus as needed SABA. A marked and observable decrease in the frequency or severity of acute episodes or interval symptoms during this trial is considered a positive response and confirms the diagnosis of asthma. It is important to emphasize that the GINA guidelines frame the diagnosis of asthma in this age group as primarily clinical. Ancillary investigations are not required for diagnosis but can be useful in certain situations, either to support the clinical picture or to rule out other conditions. For example, allergy testing, either through skin prick tests or serum-specific IgE measurement, can be helpful. Sensitization to common aeroallergens is found in the majority of children with asthma over the age of 3, so evidence of atopy strengthens the likelihood of an asthma diagnosis. However, its absence does not rule out asthma. A chest X-ray is not indicated for the routine diagnosis of asthma. It should only be considered when there is significant diagnostic uncertainty, to help exclude structural abnormalities like a vascular ring, an inhaled foreign body, or chronic infections. Lung function tests like standard spirometry are not reliable in this age group, and while more specialized tests exist, they remain largely research tools. Long-term management strategies. The overarching goal of long-term asthma management in children aged 5 and younger is to enable them to lead a normal, active life, with their condition posing minimal disruption to their daily activities, development, and sleep. This is achieved not through a one-size-fits-all prescription, but through a dynamic, personalized, and continuous cycle of care. The GINA 2025 guidelines provide a clear, evidence-based framework for this process, centered on the core principles of assessing control, adjusting treatment, and reviewing the response. The goals of management are twofold, addressing both the present burden of the disease and the potential for future risks. The first goal is to achieve and maintain good long-term symptom control. This means preventing chronic symptoms like coughing and wheezing, ensuring that the child and their caregivers are not disturbed by nighttime symptoms, and maintaining normal levels of physical activity. For a young child, Unimpaired participation in play is not a luxury, it is essential for healthy physical, social, and emotional development. The second, equally important goal is to minimize the future risk of adverse outcomes. This involves preventing severe exacerbations, which are distressing and potentially life-threatening events. It also involves preserving normal lung function and development as the child grows, and importantly, avoiding any potential side effects from the medications used to control the asthma. A cornerstone of the GINA strategy is the separate and distinct assessment of two domains of asthma control: current symptom control and future risk of adverse outcomes. This distinction is critically important because a child may have very few day-to-day symptoms, appearing well controlled on the surface, but may still be at a very high risk for severe exacerbations, particularly those triggered by viral infections. A purely symptom-based assessment would completely miss this underlying risk, leading to undertreatment and a false sense of security. Therefore, every clinical review of a child with asthma must include a formal assessment of both of these domains. The symptom control domain is assessed by questioning the parent or caregiver about the child's symptoms over the preceding 4 weeks. According to GINA, asthma is considered well controlled if the child has experienced none of the following. It is partly controlled if they have experienced 1 or 2, and uncontrolled if they have experienced 3 or all 4 of these issues. The 4 key questions are: has the child had daytime asthma symptoms more than twice a week? Has the child had any night waking or night coughing due to asthma? Has the child needed their short-acting beta-2 agonist, or SABA, reliever medication more than twice a week, not including any planned use before exercise? And finally, has there been any activity limitation due to asthma, for example, tiring more easily than their peers or being unable to keep up during play? The future risk domain involves identifying specific factors that increase the child's risk of having future exacerbations, developing persistent airflow limitation later in life, or experiencing medication side effects. The most significant risk factor for future exacerbations is a history of having had 1 or more severe exacerbations in the previous year, particularly one that required an emergency department visit, hospitalization, or a course of oral corticosteroids. Other key risk factors include having currently uncontrolled asthma symptoms, ongoing exposure to triggers like tobacco smoke or relevant indoor allergens, having major psychological or socioeconomic problems within the family, and, very importantly, having poor adherence to the prescribed controller medication or using an incorrect inhaler technique. Pharmacological therapy for asthma in young children follows a stepwise approach. Treatment is initiated and adjusted up or down based on the assessed level of asthma control. The ultimate goal is always to find the lowest possible dose of medication that effectively maintains control of both current symptoms and future risk. At step 1, for children who have a confirmed diagnosis of asthma but who have very infrequent symptoms, for example, less than twice a week, and who have no risk factors for severe exacerbations, the initial treatment is simply and as needed inhaled SABA for relief of symptoms when they occur. At step 2, we introduce initial controller therapy. This is for children whose asthma is not well controlled on as needed SABA alone, or for any child who has had 1 or more severe exacerbations in the past year, regardless of their day-to-day symptom frequency. The preferred initial controller treatment is a daily low-dose inhaled corticosteroid, or ICS. An ICS works by reducing the underlying inflammation in the airways, which is the root cause of asthma symptoms and exacerbations. A therapeutic trial of at least 2 to 3 months of daily low-dose ICS is recommended to establish its effectiveness. A less effective alternative controller option at this step is a daily leukotriene receptor antagonist, or LTRA, such as montelukast. For a very specific subset of children who have a pattern of intermittent, purely viral-induced wheezing with no interval symptoms at all, another option that can be considered is intermittent high-dose ICS, started at the very onset of a respiratory infection and continued for a short period. However, this strategy should only be used if the clinician is confident that the caregivers can recognize the onset of an infection early and will use the medication appropriately. At step 3, we consider stepping up therapy. This is for children whose asthma remains uncontrolled despite good adherence and correct technique with a daily low-dose ICS. Before increasing the treatment, it is absolutely essential to go back and confirm the diagnosis, recheck the inhaler technique meticulously, discuss adherence, and review environmental exposures. If all these factors have been addressed and the asthma is still not controlled, the preferred next step is to double the low dose of ICS, creating what is referred to as a medium dose of ICS. Finally, step 4 is for children whose asthma is still not controlled even on a medium dose of daily ICS. These children should be referred for a specialist assessment with a pediatric pulmonologist or allergist. Further treatment options, such as adding an LTRA to the medium-dose ICS, are typically considered at the specialist level after a more detailed evaluation. The correct choice and use of an inhaler device are just as important as the choice of medication itself. For children in this age group, the recommended delivery system is a pressurized metered dose inhaler, or PMDI, combined with a valved holding chamber, more commonly known as a spacer. For children under the age of 3, a tight-fitting face mask attached to the spacer is appropriate. Most children between the ages of 3 and 5 can learn to use a mouthpiece, which is more efficient and improves drug delivery to the lungs. It's crucial to educate caregivers on the correct technique. The medication should be delivered one puff at a time into the spacer, followed by the child taking 5 to 10 normal, quiet breaths. It's important to emphasize that crying significantly reduces the amount of medication that actually reaches the lungs. Nebulizers, while once common, are no longer the preferred delivery method for long-term management due to their lower efficiency and longer administration time compared to a PMDI with a spacer. Here's a look at the chemical structures of the key medications used in the management of pediatric asthma. Management of acute exacerbations. An acute exacerbation of asthma in a young child is a frightening and serious event, requiring prompt, effective, and well-organized management. The GINA 2025 guidelines provide a clear, structured approach that begins with caregiver actions at home and extends through to the protocols used in primary and acute care settings. The first line of defense is always early recognition and intervention by the caregiver, which is why a personalized, written asthma action plan is not just a recommendation but a necessity for every family. This action plan empowers caregivers by teaching them to recognize the signs of worsening asthma. These signs include an increase in coughing, especially at night, the onset or worsening of wheezing, observable shortness of breath, a reduction in the child's usual activity level or interest in feeding, and, critically, a poor or diminishing response to their as-needed reliever medication. The action plan provides clear instructions for initial home treatment, which begins with the administration of an inhaled short-acting beta-2 agonist, or SABA, typically 2 puffs administered via a PMDI and spacer. If the child does not improve, this dose can be repeated up to 2 more times at 20-minute intervals. Just as importantly, the action plan must provide unambiguous criteria for when to seek urgent medical care. Caregivers should be instructed to seek immediate help if the child is acutely distressed, showing visible signs of severe breathlessness like subcostal or intercostal retractions, or has any cyanosis, which is a bluish discoloration around the lips. Other urgent indicators include the child becoming drowsy or lethargic, symptoms worsening despite the administration of SABA, or if the child requires 4 or more puffs of SABA in less than a 4-hour period. When a child presents for medical care with an exacerbation, the clinical team must perform assessment and treatment concurrently. The severity of the exacerbation is judged clinically, based on a combination of signs. A child with a mild exacerbation may be wheezing but is otherwise comfortable, alert, and speaking in full sentences. In contrast, a child with a severe exacerbation will be distressed, possibly agitated or drowsy, and may only be able to speak in single words or have a weak cry. Their pulse rate will be elevated, greater than 180 beats per minute for a child under 3, or greater than 150 for a child aged 4 to 5. They will be using accessory muscles to breathe, and their oxygen saturation will typically be less than 92%. A particularly ominous sign in a child with severe respiratory distress is a quiet chest on auscultation. This does not mean the child is improving, it means there is such severe airway obstruction that there is minimal air entry, signaling impending respiratory failure. The goals of acute treatment are to rapidly reverse the bronchoconstriction, correct any hypoxemia, and reduce the underlying airway inflammation to prevent a relapse. The first step is to administer supplemental oxygen to maintain the oxygen saturation at or above 94%. It is important to be aware that pulse oximetry can sometimes overestimate oxygen saturation in children with dark skin pigmentation, so careful clinical correlation is always required. The cornerstone of pharmacological treatment is inhaled SABA. For moderate to severe exacerbations, an initial dose of 4 to 6 puffs of salbutamol, at 100 micrograms per puff, should be given via PMDI and spacer. This dose can be repeated every 20 minutes for up to 3 doses in the first hour. For any child with a moderate to severe exacerbation, inhaled ipratropium bromide should be added to each SABA dose. For the first hour, ipratropium is a short-acting muscarinic antagonist that provides additional bronchodilation through a different mechanism than SABA, and their effects are synergistic. A typical dose is 4 puffs of 20 micrograms per actuation. Alongside these bronchodilators, systemic corticosteroids should be administered promptly for all but the mildest exacerbations. Oral corticosteroids, such as prednisolone, are crucial for reducing airway inflammation and preventing a delayed worsening of symptoms. The recommended dose is 1 to 2 mg per kilogram per day, with a maximum of 20 mg per day for children under 2, and 30 mg per day for children aged 2 to 5, given for 3 to 5 days. For children who do not respond adequately to these initial therapies, further interventions are necessary. Here, the GINA 2025 guidelines provide important, evidence-based updates. The guidelines reinforce the recommendation to consider a single intravenous dose of magnesium sulfate for children aged 2 years and older who have a severe exacerbation that is not responding to intensive initial treatment. The typical dose is 40 to 50 mg per kilogram, with a maximum of 2 grams. Recent meta-analyses have confirmed that this intervention can reduce the rate of hospitalization in this specific population. However, in a key practice-changing update, GINA 2025 now explicitly no longer recommends the use of nebulized magnesium sulfate. This is based on a review of the evidence which has failed to show a clinically significant benefit for nebulized administration in this age group. This important clarification helps to streamline emergency protocols, allowing clinical teams to focus their resources on interventions with proven efficacy. Ongoing monitoring and advanced insights. Effective asthma management in preschool children is not a single event but a continuous, collaborative journey. It requires a strong partnership between the healthcare provider and the child's caregivers, built on a foundation of regular communication, education, and shared decision-making. The GINA 2025 guidelines emphasize a cyclical approach of assess, adjust, and review to ensure that treatment remains perfectly tailored to the child's evolving needs. Long-term management should be structured around regular follow-up visits, typically every 3 to 6 months. A crucial consideration in this age group is the natural history of early life wheezing. Many children who experience asthma-like symptoms in their preschool years will have a spontaneous remission of their symptoms as they get older. Therefore, the need for continued controller therapy must be regularly and formally reassessed. This careful approach prevents both the undertreatment of children with persistent disease and the unnecessary overtreatment of those with transient symptoms. Each review visit should be comprehensive. It must include a formal assessment of asthma control, evaluating both symptom control over the past 4 weeks and the ongoing risk factors for future exacerbations. It is also a critical opportunity to address treatment issues. This means physically checking and correcting the caregiver's inhaler technique, having an open and non-judgmental conversation about adherence and any barriers the family may be facing, and reviewing their understanding and use of their written asthma action plan. Monitoring for potential side effects is also a key component of these visits. A particular focus should be placed on measuring the child's height at least annually, as high doses of inhaled corticosteroids can, in some cases, affect growth velocity, particularly in the first 1 to 2 years of treatment, although the effect on final adult height is generally minimal. The process of adjusting therapy, either stepping up or stepping down, must be systematic. Before escalating treatment for what appears to be poor control, the clinician must first rule out the common mimics of poor control. This involves reconfirming the diagnosis, meticulously rechecking inhaler technique, and discussing adherence. Environmental factors, such as a new pet in the home or increased exposure to tobacco smoke, should also be investigated. Only after these factors have been addressed, if the asthma remains uncontrolled, is a step up in therapy warranted. Conversely, de-escalation of therapy is an active and important goal. The aim is always to find the minimum effective dose that maintains good control. GINA recommends that if a child's asthma has been well controlled for at least 3 months, a step down in treatment should be considered. Any such step down should be treated as a therapeutic trial, with a follow-up visit scheduled 3 to 6 weeks later to ensure that control has been maintained at the lower dose. The period immediately following an acute exacerbation is a critical juncture. An exacerbation represents a failure of the current management strategy and is a powerful predictor of future risk. This is a crucial opportunity to re-evaluate and optimize the child's long-term care plan. Before a child is discharged from an emergency department or hospital, caregivers must receive clear instructions, a review of their inhaler technique, and an updated written asthma action plan. A child who has had a severe exacerbation is, by definition, at high risk for future events, so it is essential to ensure they are on an appropriate daily controller therapy. Most importantly, a follow-up appointment with their primary healthcare provider should be scheduled within 1 to 3 days of discharge. This early review is crucial to ensure the exacerbation is resolving completely, to identify and address the factors that may have triggered it, and to reinforce education and adjust the long-term plan to prevent a recurrence. This proactive follow-up is essential to break the cycle of recurrent crises. Looking to the future, research continues to refine our understanding and management of preschool asthma. There is growing interest in the role of the airway microbiome and its influence on local immune responses. Researchers are also actively seeking better biomarkers to predict asthma persistence and guide therapy, although tools like fractional exhaled nitric oxide, or FeNO, are not yet ready for routine clinical use in this age group. The development of biologic therapies, such as monoclonal antibodies that target specific components of the Th2 inflammatory pathway, has revolutionized the treatment of severe asthma in older children and adults. While these therapies are not currently approved for children under 6, ongoing research may one day extend their benefits to the youngest and most severely affected patients. Conclusion: as we conclude this detailed discussion on the management of asthma in children under 5, based on the GINA 2025 global strategy, let's distill our conversation into a few key take-home points. First, the diagnosis of asthma in children aged 5 and under can and should be made. We must move away from ambiguous labels like viral wheeze, and embrace the GINA criterion-based framework, which relies on a characteristic pattern of symptoms, the exclusion of other diagnoses, and, most importantly, a documented therapeutic response to asthma medication. Second, long-term management is a continuous cycle of assessing, adjusting, and reviewing. We must separately evaluate both current symptom control and future risk factors for exacerbations. The stepwise approach to therapy, with daily low-dose inhaled corticosteroids as the preferred initial controller treatment, allows us to tailor therapy to the individual child's needs, with the constant goal of finding the lowest effective dose. Third, the correct use of delivery devices is paramount. For this age group, a pressurized metered dose inhaler with a valved holding chamber, or spacer, is the recommended system. Regular and repeated education on correct technique is just as critical as prescribing the right medication. Fourth, the management of acute exacerbations must be structured and swift. Every family needs a written asthma action plan for early intervention at home. In the acute care setting, treatment should be guided by severity and includes oxygen, repeated doses of inhaled short-acting beta-2 agonists, the addition of ipratropium bromide for moderate to severe cases, and prompt administration of oral corticosteroids. Intravenous magnesium sulfate remains an important option for severe, refractory cases in children over 2, but nebulized magnesium is no longer recommended. Finally, effective asthma care is built on a strong partnership with the child's caregivers. Through education, shared decision-making, and proactive follow-up, particularly after an exacerbation, we can empower families, reduce the burden of this common chronic illness, and help every child with asthma to breathe freely and thrive.